So, good evening, everyone. Welcome to this educational session. This session is determining physical capacity and is funded by Return to Work. Say, my name is Maria, and I'm a part of the Submia team. We're running this session with Return to Work. Well, to begin, I would like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay tribute to their physical and spiritual connections to land, water, and community, enduring now as it has been throughout times. We pay respect to them, their cultures, and to elder past, present, and emerging. So some housekeeping points to consider this night. Well, for those participants that are in the room, please place mobile phones on silent. So toilets are located on the other room. Outside this room, turn it to the right. Yes, in the door. Well, you will find some resources printed there in your desk and the evaluation form for you to complete at the end of the session. And the statement of attendance will be sent tomorrow after this session. Well, so I would like to introduce the presenters this night. Well, we have Dr. Tan Ha. She's the medical advisor for Return to Work. She has a special interest in the prevention and management of work injuries. She has over 7 years experience solely in the occupational medicine arena, preceded by 10 years of surgical experiences and 8 years of physiotherapy experience before that. And she has also completed a PhD in surgery. Thank you for being here. Also, we have Fiona Belton, that she is an accredited exercise physiologist and accredited exercise scientist. She has been the exercise physiologist advisor at Return to Work SA since 2020 and continues to maintain her clinical expertise through her own business and a clinical lead role at a large multidisciplinary private practice. And also we have Cassandra Saina this evening with us. She's a specialist occupational health physiotherapist and is a dual title musculoskeletal pain physiotherapist. Cassandra is a passionate clinician with over 30 years private practice and occupational health experience and works as a lecturer at all Adelaide universities. So, well, I would like to invite Tan, yes, if you want to come here and start the presentation. Thank you.
Thank you very much for joining us tonight, everybody. I've already had some chats with people and I touched them. Welcome to the people online as well. Am I looking at that camera over there, guys, for the online people? Hello, welcome. So thank you for the introduction, Maria. I won't go through that again because I only have half an hour to talk. And then those who know me well, I can talk for well over half an hour on lots of things. So I'm going to try and keep everything very, very truncated today. Determining capacity is a big topic that we can talk about for hours and hours, but I'm trying to bring to the table a practical approach today. So I'll be talking a little bit about the theory and about the evidence behind why we do what we do. But what we're going to try to do tonight is to make it interactive, and we're going to break out into groups a little bit later on as per the plan on the table. And we're going to have a little go at determining capacity for some patients that we have prepared. So the learning objectives for today is firstly to utilize a range of tools to try and determine what it is that patients can do right now, what is safe for them to do, and what they can confidently embark out into the world to do right now. Then we can also use different tools to work out what it is that we think they can do in the forthcoming future, in the short term as well as the medium and long term. We'll also reviewing the return to work essay forms, and we've got some of those printed out on the table. So we'll be filling those in as a group, and then we'll have you guys presenting it to us as well, the decisions that you've made as a team. And then we'll also be looking at ways to conduct ongoing reviews as well. So how often to review their progress, how to upgrade their capacity or downgrade capacity, if that is the case, and really adapt what they're doing to their to what we see from a clinical point of view. Okay, so that's our learning objectives for today. I'm going to tackle it from a what, why, how, and do perspective. What is the return to work scheme? So that's looking at a little bit of the overview. What is the role of ourselves as a GP as well as the allied health provider? So those who went to our last talk last year, it was very much more focused on just the GP role. So this year, what we're trying to do is trying to incorporate a more multidisciplinary team approach into the management of work injuries. Why we do it? So this is where the evidence will come in and how we do it, which is that interactive part. And then we'll do it in 3 case studies. So we'll break out into groups. I'll run the face-to-face one here, and then Cassandra and Fiona will run one each in online for you guys. Jump in with any questions. Now, because we are limited for time today, what I have decided to do is we're only going to talk a little bit about the return to work scheme. If anybody is interested in more in depth about the scheme, how it works, how it's funded, where the money goes, etc., happy to talk about that after, but it takes up quite a chunk of time. So I'm going to reduce that one so that we can spend more time on the others. And also the last year, Dean, you would have seen I spent a fair bit of time on common obstacles, which I feel is really, really useful and important because they're actually the stumbling blocks for a lot of patients that come to see us. However, they also require a lot of time to go into as well. So I'm happy to send out some slides after today. Last time I had 3 hours to talk. Today I have to share it. So with the common obstacles, I have 4 common responses that we often see in GP land. Responses such as, it's too painful, I can't go back to work, or doctor, I know my body, I know that I'm not ready to go back. I just need 2 or 3 weeks off, and then I'll be right as rain and I'll be going back then. So these are some very common requests or responses that we hear from our patients in the clinic. And I've got some tips on how to go about circumventing some of those responses and perhaps using them as opportunities rather than obstacle blocks. Okay, so that's quite meaty and chunky. If you guys, online included, feel that at the end of this that you would like another seminar or another talk or even a webinar on common obstacles, perhaps we can have a chat to SAPMEA or return to work essay, and I can present just that chunk, which probably will take an hour in itself. Okay, and then the multidisciplinary team, I'm going to hand over to Cass and Fiona. So a little bit about the scheme. This is a very busy slide. I don't want to spend too much time on it. All I want to say, can people... Oh, yeah, oops. Okay, so this is a diagram that comes out every year from Return to Work SA of some of the stats that go through the system. Changes every year, but only very slightly. Most of the proportions are fairly much the same. It's rised a little bit this year, but the way that we look at it is that this is the most current one. The next one will come out in September this year. So this is for the last financial year just then. There were 61,000 employers that were insured with Return to Work SA. So that's not employees, that's employers, that's companies, 61,000 companies in South Australia that are under the Return to Work scheme. When I say under the Return to Work SA scheme, what that means is that they are insured by Return to Work SA. Now, they make up about 2/3 of the industry companies in South Australia. The other 1/3 are large companies such as Coles, Bunnings, Woolies, Wesfarmers, Kmart, those kind of big companies, they're self-insured. So you may find that when someone comes into the clinic, they may be either insured under the Return to Work SA scheme, funded by Return to Work SA, or they might be funded by their own company. Okay, so the logistics are slightly different. However, the legislation is exactly the same. And that's where Return to Work SA come in as an overriding regulator. So Return to Work SA have two roles. One role is to act as the funding body for insurance, and the other role is to be an overriding regulator for all companies, even the ones who are self-insured, just to make sure that they follow the rules and the laws and things like that. So of the 2/3, 61,000. So they charged just over 700 million. And the total number of claims is 25,000, half of which are about old claims that have come through from the previous year and half of which are about new claims. Okay, so about 25,000 claims altogether. The interesting thing that, and then there's a whole heap of other information on where the money goes, what sort of industry it comes from and a spread like that. But what I find very interesting is this bit here, the return to work rates, 4 weeks, 13 weeks, half a year, and then 104 weeks, which is 2 years. This is important because at this point in time, all income support stops, okay? Medical support still continues for a year, but that income support stops. So patients get very, very worried around about this point here, 18 months. Okay, so sometimes you'll get patients come, never having worked a day after their injury at 18 months, coming to your doorstep and saying, I've just got a letter from Return to Work SA and they're cutting all my funding in 6 months' time. And by then, it's really, really late and really, really difficult to get them back into full-time, full-paying work. Some work, yes, but full-time, full-paying work, very difficult because they've been off for so long. But having said that, the rate is pretty good. It's about 96% by the time they get to the end of their entitlements. This rate is also very good. 4 weeks, over 80%. 4 out of 5 people have gone back to work already by 4 weeks post-injury, which is really, really good. South Australia is leading in those rates, so that's something that we are very proud about. However, we're running these sessions so that we can improve that number even further, even though we're doing so well already. And then the rest of them are really, a different kind of jobs and industries that it all comes from. So I'll move on from there. Any questions, guys? The role of the GP? Okay. The role of the GP. So role of the GP in managing work injuries is very similar in any other patient that comes along, except for the last bit. So really, if we look at, this is a document from the RACGP with the underlying principles for managing patients in general, and we've all seen this before, so I won't dwell on this. Principle 1, Principle 2, exactly the same, so advocacy and assessment. This is the part that is different in managing work injuries versus your common every other day injuries or ailments that patients come in with. And the reason being is that GPs perform a much more collaborative directory role in these patients. It's not so much that we do the work to fix them. It's very much a role of stepping back and getting a whole team of people to come in to try and fix different parts of the problem, where those problems may be. Some of those problems may be very few, but some of those can be very complex that we need a really good team for. And we'll touch on how we can do that. So I've made this, tried to make this simple to sort of remember. I've put the first two as W. W is to work out, what is wrong, work history, who can help. That's easy. That's what we do all day, every day. And then the third principle, principle 3, I've divided into CC, and conveniently it's WCC, work capacity certificate. And the CC for is so the CC stands for, sorry, I skipped that slide, but it was to stand for collaboration and coordination of care, which we will spend most of our time on. So with the W, the work history, examination, investigations, all the same. So I'm not going to dwell on that. Physical and pain assessment tools as well as mental health tools. So these are some of the tools that we can use from an occupational medicine point of view that may help us. And I think Cassie will talk a little bit later on the FAB tool. But what I wanted to bring up was the Arebro. Has anyone heard or seen the Arebro before? No. So the Arebro is the shortened form of the Arebro is a validated tool that can help GPs and other professionals like physios and OTs and exercise physiologists to work out the risk of patients not doing well effectively from their work injury. Listed 10 questions, and basically if each question is scored out of 10, and if the score is above 50, you add up the scores at the end, the score is above 50, we can send a form out at the end of the session electronically. If the score is above 50, they have a higher risk, and it's a validated tool. So it's been shown and proven that they have a higher risk of extended recovery from a work injury. So in those cases with the Arebro tool, what we can use that for is if we do that on an initial presentation, we can then start instigating things like psychological assessment and help, extra physio help, work site assessments, exercise physiology, psychology, some of the services that Return to Work SA may have, which I can talk about later as well, some of the psychological services, mental health services, and these can all be free to the patient. So all of these services can be instigated based on this tool. So sometimes it's very difficult. You know, when a patient walks in, you think, oh, are they going to get better? They're not going to get better. Going to get better. Sometimes it's very obvious. And therefore, you may want to instigate it straight away, but sometimes it's very grey and it's very, and someone who you think is going to do well ends up not doing well, or someone who you think is not going to do well ends up doing well. So this is a very objective, easy to use 50 above or 50 and below. And this tool is often used in work injury clinics. Dean, you would have seen this tool in a lot of the work injury clinics. Every patient who walks in the door will get this form. And it's often a good form to use as a follow-up as well. So what we might do is use it on initial consultation and then 6 weeks later, 3 months later. Okay, so that's the Arebro. Then there's the mental health assessment tools as well. And I think your GPs would have seen this in their clinics. Yes? No? Yes? No? The full document is long, but there is a 2-page truncated summarized version, which we'll also include in the talk when we send out the talk as well. And this is very useful in diagnosing as well as managing mental health component of injuries. And as we know, the mental health component can be a very big component, even in physical injuries. So it's a good way to just it's a quick checklist to work out which patient may require a little bit more help right at the front end, rather than waiting till 18 months down the track and going, how do I help you now? Okay, so that's a good tool to use as well. And that's a good one to have just stuck on your wall next to your computer and referring to that, when a work injury, you can use it for any patient, but we particularly use it, for the work injury patients to assess and triage them from the beginning. So a little bit more about the tools. Then you've got your medical body guidelines and your industry guidelines as well. Now, this one is a document that came out just last year. No, 2 years ago now, 2022, April 2022. And this is actually aimed at everybody, not just GPs, not just allied health, but also the claims managers, the employers. It's a document that looks at every component of managing a work injury. And the main things that came out of that is that really sometimes it's not even about the physical injury itself, or not even about the way that you manage the physical recovery or the rehab. It's actually, a lot of it has got to do with the patient feeling cared for. And that's why the document is entitled It Pays to Care. So basically, as clinicians, as allied health clinicians, as claims managers, it pays for us to care, or at least look like we care about the patient. Okay, so if the patient feels that they're being supported from an industrial point of view, medical point of view, allied health point of view, and a claims point of view, these patients have been shown to do a lot better than patients who feel that they aren't cared for. All right. So the idea here is that really it's not just about organising what investigations they need, or tick the box for physio, tick the box for analgesia, and then have them come back in 6 weeks. It's really about delving into how to really make them feel like they're being supported. But you can get help in that regard. I mean, we have limited time in the clinic. We can't spend 45 minutes with every patient listening to all their problems and making them feel cared about. But there are ways that we can get the whole team involved to make them feel like they're being supported and cohesively. And then there's industry guidelines. So then Return to Work SA have a clinical framework as well. So this is available on the website. And this just outlines how we can, mainly from the medical point of view, can optimise our management of injury patients. And so the C is to certify capacity and to collaborate care. So with certifying capacity, that's the EWCC. Well, it's the WCC, which is the Work Capacity Certificate. These days, though, we are trying to promote the EWCC. The paper WCC is being phased out. Can I get a show of hands who here already uses the EWCC, online included? Excellent. Yeah, so we've been trying to, Return to Work SA and I, and now 2 more medical advisors are trying to go out into GP land. Oh, sorry. I'm trying to go out there. Can we move this keyboard? Thank you. I'm trying to go out to GP, trying to. Excellent. For those who don't know how to use the EWCC, it's linked to the health links as part of your medical record system. So if you haven't got that already instigated into your systems, let me know at the end, and I can put you in contact with Return to Work SA. Yeah. Yeah, yeah. Very time consuming. So for those online who may not have heard Rajani, is that how I say it? Rajani, is that she was reporting that, well, she's tried to use EWCC and it hasn't been working very well online. So she's been printing out the form and then hand writing it and then scanning it and then distributing it. So yes, that is one way to do it, probably the long way to do it, Rajani, but the EWC shouldn't be that hard. And so there must be some problem with the system. So what we might do is, if anybody else has this problem as well, anybody? No? I might grab your number at the end and contact you directly, and we might come out to your practice, have a look at the system and see where the problem is. Okay. And it's run through, Telstra, so we may have to get them involved as well. All right. Anybody online have this problem as well that I might need to contact? Yes, Cass. Absolutely. Yes. Yes. Yeah. Yes. Yeah. And actually, it will be them that will help you, not me. But we can come out to the practice and check the system, or do it via web or something. Yeah, yeah. But it shouldn't be a problem. It shouldn't be that difficult. It's meant to be easier, not harder. Yeah. But thank you for letting us know, because occasionally from time to time we do get that comment when we do go out to GP clinics to talk about the system. So sometimes we do have that problem. Okay, so that's the EWCC. So now for the evidence. Any questions? Why do we get them back to work early? Why don't we just leave them at home and let them recover at home and then send them back when they're ready? Be much easier for us. We just need to tick one box. Don't need to write anything. Don't need to tick any other bits of the section E. See them in a couple of weeks and then see how we go then. And it's safe, right? It's safe. You know that you're not going to put them back to potential risk of re-injuring themselves. So it's tempting. It's very tempting to say, yeah, sure, try a couple of weeks off and we'll see how we go. But why? Why should we not? So the evidence is, and this is real evidence, real stats, the evidence is that I've already shown you that 83% in South Australia return back after 4 weeks. But the longer people stay off work, the lower their chance of ever returning back to any kind of work. And we're talking about reduced hours, reduced duties, any kind of work. So the longer they stay off, the worse it is for them. After 20 days, the chance of returning back to work is 70%, 2/3. That's not too bad. After 20 days, 45 days, 50%. But by the time they get to 70 days, they're right down to 35% of ever returning back to any kind of work. So the earlier we can get them back, the better. The evidence is that they rehab better at work. The converse is also true, is that work absence, work disability, underemployment, unemployment is all in all bad for health, bad for society, bad for self-esteem, bad for mental health, bad for physical health, causes, contributes, and accentuates negative and physical health impacts. So these are from statements from the RACGP. So it's all been documented that we should really get patients back to work as soon as we can. Doesn't stop there either. When patients are off work, it also affects their families. So then you've got a knock-on effect. So then you've got their children who are then being disadvantaged as well as problems with spouse and things like that. So it doesn't just stop at the patient. So the earlier we can get them back, the better. And then there are positive health impacts as well. So work is generally good. And this one's from both the RACGP and the RACP. Work is generally good for health and well-being and creates lots of advantages in lots of areas, including physical activity, community involvement, sense of self-worth, financial security. So lots and lots of good benefits of being at work. So certifying capacity. I am zooming through this, so if you want me to slow down, I can, but I'm trying to get to the meaty part. A practical approach. Section A, if you have a look on the form, A, B, C, D is very easy. So they're all demographics, how did the injury happen, etc. So they're easy. If you don't know how the injury how the injury happened should be basically based on the history. But if you don't know what the diagnosis is, it doesn't matter. It really doesn't matter. Really, they need this as a legal form to put in a claim. So patients can't put in a claim until, they put in a claim, but they must present a medical certificate from a GP following that claim to make it valid. So therefore, you may not have the answer at the first consult or at the initial consult. You may not have done the necessary investigations or you may not have even finished the examination. They may have been booked in for 10 minutes or even 6 minutes. And you think, oh my gosh, it's a work injury. Where do I start? I've got 10 patients waiting. So you may not even finish the assessment, and that's okay. All they need to start with is a form to say that you've seen them and that they can start on something if you feel that they can start on something. And if you don't know what the diagnosis is, move on. You can come back to that later. Maybe if you don't know, though, it's better to sort of be under rather than over prescriptive with the diagnosis, because then if you put something down that's very specific, then you may need to undo that later. So probably, for example, if you suspect that they've ruptured their ACL, right? But you haven't yet done this, you don't exactly know for sure that they have, but clinically they have ruptured their ACL. It's probably better to just start with, injured knee, query ACL as opposed to definitely, because as soon as you put a definite diagnosis, then the ball starts rolling. Okay. And so it's probably better just to hold back a little bit on that first form. So if you can't fill it in, that's fine. The meaty bit is the E, the functional capacity part. Now, this part is the bit that I don't want to say scares, but really is unattractive for busy doctors because there's lots of boxes to fill in. And really, it's sometimes it's difficult to work out what it is that they can and can't do. So before, it used to be fit, unfit, sick, not sick. It was very black or white. It was very yes or no. Yes, you can go to work. No, you can go to work. But these days it's different. Now, or it's all about what they can safely do now, as opposed to what they can't do. So if you've noticed, it's now called a capacity certificate, as opposed to, it's what they're capable of doing. So we're really trying to focus on the positives as opposed to the restrictions. So it's no longer, termed movement restrictions or task restrictions. It's really their capacity. Dean, did you have a question? Oh, okay. It's like being at an auction. So this is the part where so the form has a pro forma. It's got, things standing, sitting, lifting, pushing, pulling, etc. But you don't have to follow that pro forma if you don't want. This is just really to make things a bit easier for us, so that all that we need to do is tick boxes. But if you have something very specific that you want to write, there's a big giant box next to the tick boxes that you can put as much or as little information as you want. Online is the same. There's a box online that you can just put physical words in that aren't specifically in the box. Now, when we do get to the box, this is not everything, but just a little taster for what, little ideas that we can use. So if a patient comes in and goes, I can't lift anything, there are no light duties for me at work. I can't do anything. I can't go back to work. Everything we do is having to lift heavy boxes, and I have to walk very far, and I can't do it. I just can't go back to work. These are some things that we can maybe suggest to the patient to see if perhaps maybe there is something that they can do, albeit small. So, for example, sitting. Can you sit for dinner? Yes, no, yeah. So most people can sit for dinner. So if they can sit for dinner, they can sit for 15 minutes. Okay. So, and if if they've got an active moving about job, perhaps that they can do another role that is more sedentary, but they could sit for 15 minutes and then get up and maybe walk around and change postures and then come back and sit for another 15 minutes. Can they sit and watch The Bachelor? I don't watch TV, so or the Game of Thrones, or I did watch Twilight though. That was 15 hours. So, and I may not have left my seat for 15 hours, so I can sit for 15 hours. I'm pretty sure I did a marathon for that one. So, but for one episode, of one movie, can you sit for a movie? Can you sit at the cinemas? Can you sit at the pub? Can you sit and talk to your friends? So pick something that they can relate to. It doesn't always, if they're obsessed about food, then it might be dinner. But if they're not obsessed about food, but they love drinking, then perhaps you can talk about, something that they do love doing. So just pick something that you can put a physical or an objective measure to. And that also is only an estimate. So it doesn't have to be 15 minutes. It can be half an hour. It can be, just pick something that they can relate to. Or another way to do it is asking them what they can do in terms of, what do you do that requires you to sit, and how long can you do that for? But the answer often to that is no, I can't sit. And then you have to suggest. So walking, can you walk to the letterbox? Can you walk down to the street? Can you walk around the park? And same with carrying, holding, and lifting. Can you lift your phone? Okay, so that's not zero. That's something. They can lift their phone. Everyone can lift their phone. Can you lift a cup of tea? Can you lift a bottle of milk? Can you lift half a bottle of milk? Can you lift a spring water bottle? Just little things that they do every day that then they'll go, well, actually, maybe I can. And then we use those to then incorporate into what they can do in terms of capacity. So then you don't, so the important thing to think what have I got here? Yeah, all right. I do often have another one as well, which I took out, is, did I put it in there? Anyway, so you get the idea. So, things like kneeling and squatting, lifting laundry baskets, anything, if they're at home. Lifting babies is another one. How heavy is your kid? If they've got a 2-year-old, 30 kilos, right? Or maybe less. My 2-year-old was 30 kilos. It was very fat. but something that's related to them on a day-to-day basis. And then you can apply that to all the other things as well. Reaching above shoulder, if they like caravanning, last weekend we went camping, and water skiing, kneeboarding. But can they reach up and pull down the awnings from their caravan? Things that they love doing. Some people, I've had people who come in and play pool. They just play professional pool, but they have a shoulder problem, right? So, but they're still playing pool, but they can't go to work because they have a shoulder problem. So just things that they do, and that might need a little bit of delving into their personal life. So the idea is to promote active strategies to get them moving. So, and what I mean by active is that it is getting them to do things that require them to move around, even in their breaks. So when we go, sit for 15 minutes, if you can, then get up and walk around, or walk for half an hour and then come and sit down. When they come and sit down, they don't just sit and do nothing. They sit and they ice, or they sit and they elevate, or they sit and they do their exercises. And if you're having and if you're not sure about what exercises they might be able to do while they're sitting, that's when you get, your friends from the allied health team to get in and maybe prescribe them something. Hey, Cass, can you maybe give them a 5-minute exercise program that they can do 3 times a day? Not their specific proper exercise program, but something that they can do while they're having their active rest breaks. Intersperse the activities, you've seen all of these things before, non-repetitive, sustained movements, allow breaks, consider outdoors. They don't always have to be indoors either. And then other opportunities. So equipment, you can get an OT to assess for sit-stand desks, perch stools, and other types of adjuncts to movement that you can use to promote or to facilitate their return to work, even if it's just a little bit. And then looking at, and this, I haven't got it here. It is another big talk, but there is also an approach to how to manage psychological injuries as well. So we do a different talk for that, but just as a very quick, brief overview, with psychological injuries, sometimes what you may have to think about is shifting their environment. So if you can't shift what they do, because there's nothing physically wrong, that there may not be anything physically wrong with them. So they can sit at the desk if they have a sedentary job, they can lift, but they just can't be there because of a psychological injury, then you may want to consider perhaps taking them out of that environment and putting them somewhere else. So sometimes companies may have other sites. So, and this is where a case conference, we'll talk about in a minute, will come in so that you can get everybody in the same room and work out how to overcome these obstacles. So do we take them out of that site and put them in another site? Do we change their task? So, do we take them out of catering and put them into lifestyle for a little bit? Or do we change the people that they work with? Instead of working in welding unit A, can they go to welding unit B? So there's all of those sort of strategies as well that you can use. It doesn't always have to be a physical strategy. You can, there's different ways you can get around with problems if they can't work where they are at that time. Okay. And then how often do we see, and then, so what I do is I look at what they can do before I work out how long they can do it for. Because if you start up front with how, oh, do you want to go back to work 3 times a day? 3 times a week or 5 times a week? It's overwhelming. It's well, what am I going to do at work for 3 days a week? But if you start with what they can do, then it kind of eases them into, yeah, I can do that. And yeah, maybe I can do that for 3 hours a day. A good place that I start is 3 times a day, 3 hours a day, 3 times a week. 3 hours a day because, minimum pay is 3 hours. If you go to any job, they don't pay you for less than 3 hours. So 3 hours is reasonable. By the time you get there, make yourself a cup of tea, walk around, talk to someone, it's already an hour. And then it's take your time. Social, and work's about socializing and keeping, those contacts as well. So so very important, that first hour of walking around doing nothing, first 3 hours of walking around doing nothing is actually very important. And then really the last hour could be, slowly packing up and getting your gear and tidying up. And then really it's only an hour in between. So these are some of the things that you might have to say to the patient as well, it's okay. 3 hours does sound like a lot, but really think about it. You know, what can you do? What might you do? Another way to think about it is to think, well, what would you normally do at home? You know, like, we wouldn't expect you to do anything more at work than you would be doing at home. So what we want to try and do is simulate what you do at home. Do you have a couch at home? You sit? Great. Let's get you into the, you know, let's talk to work about maybe getting a chair of some sort into your office, or, you know, so what is it that you do at home that we can simulate at work? That's another way that we can look at it as well. Okay. And then talk about the hours, minutes in a shift, hours in a day, days in a week, and then set a review date. So after a long time, I worked out that it's actually no point seeing patients after a week, because they always complain. And it's very demoralizing, because then you think, oh, I've done the wrong thing, and they're bad and they're worse. And then you start going backwards, and then, you know, and that's not good for confidence. It's not good for yourself. And it's not good for the employer either, because then they start losing faith as well. So now I actually say, unless they're urgent, you know, unless you've got, you know, concerns about them, and some of the psychological cases, you might need to see them after, you know, 24 hours, 48 hours, if you're very concerned. Some of the acute injuries may need to be seen earlier, but those who are kind of chugging along and you're just trying to get some capacity, I usually go with 2 weeks. First week is usually bad. Okay. When I say bad, it's not really bad. It's just that, you know, they're re-engaging with work. And yes, things do hurt a little bit more. Things, you know, don't feel as comfortable, but the second week is always better. So I generally see them after 2 weeks. And that is another important point, is expectations. We really need to talk to the patient about what to expect. And so if you set them up with, hey, really that first week may be a little bit sore, but it's okay. What we're aiming for is not zero. We don't want zero pain, because you don't get zero pain at home, right? What we're aiming for is maybe about anywhere from 0 to 3. 0 to 3, 4 pain is okay. Push through, take a break, change your environment, change your posture, and just keep it somewhere between in that lower third. If it pushes up above a 3 or 4, then perhaps change, you know, some of the actions, or try to get that back, use some ice, elevate. But if it does go up above the 7, 8, then come back and see me. That's generally what I say. Otherwise, you'll get patients coming back, go, no, it hurts. But it hurts is not good enough. The it hurts needs to be objectified to work out, well, is it a bad hurt? Oh, are we moving on? Okay. And think of it as a prescription or a communication tool. Basically, what you write on the form is what has to happen. The claims manager will make it happen. If you need a case conference, they'll make it happen. If you need a worksite visit, they'll make it happen. Job placement services provider, all of that. They're okay. And oh, was that my last slide? Excellent. Good. I think I have more at the end though. Thank you.
Oh, thanks, Tan. So much information. It's such a wonderful way to listen to you present. I love it. So my name's Fiona. I'm the exercise physiology advisor, as was introduced earlier, and Cass is here with us as well, the physiotherapy advisor. So we're going to talk to you a little bit today about what happens from the allied health professional perspective, because as Tan mentioned, you know, we are part of the treating team. We're here to help you as much as we are here to help the injured worker. So we want to be able to make sure that we're all sort of singing the same song and working together to make sure that we're getting what we need done. So how do we determine functional capacity? So from an allied health perspective, and when I say allied health, it could be exercise physiology, it could be physiotherapy, OTs, a whole bunch of other people. We look at a lot of different ways that we can do that. Firstly, as Tan, I feel like you've already stolen half my presentation, Tan, so it's awesome. So from a subjective perspective, absolutely, we ask the injured worker. You know, it doesn't have to be a finite, you know, if you tell me that you can sit for 60 minutes, we're going to make you do that. It really is about trying to get some subjectivity and engage them in the conversation, because when we do that, it helps them take a little bit of ownership over what it is that they can do. So as I said, we are talking capacity. So things like, you know, when the conversation starts off, I can't lift, again, as Tan mentioned, well, what can you do? What is relevant to you? What conversation can we have? The good news is, as an allied health professional, certainly as an exercise physiologist, we do get time. And I remember when Tan was starting her presentation, we acknowledged the fact that as GPs in particular, there's not always the time to have these conversations. So as allied health professionals, we do have time. We often have 30, 45, sometimes up to 60 minutes with the injured worker. So we can go through these questions, and that's how we can help you. We do have our screening and outcome measurement tools. Tan mentioned a little bit about the Arebro. Cass is going to touch on that a little bit more, but there are a number of different sort of validated, standardized outcome measurement tools that we can utilize as allied health professionals, which help to determine more and more about what this capacity is looking like. Tools like the Oswestry low back form, we can look at shoulder pain and disability index. So there's a whole range of different tools that we use to do that. As allied health, we also have our own ways within our scopes of practice to actually measure and look at objective assessments. We look at different functional tools. So physiotherapists might do something different to what an OT would, might do something different to what an exercise physiologist would, but it's all still formed as part of our assessment processes, which hopefully adds more value to what you're also assessing. And then the last two, we know when we're looking at the diagnostic side of things, as Tan mentioned, it's not always about sending off for interventions, but what do we know about the way that this injury is presenting? What do we know about the mechanism behind the injury? What do we know about that healing timeframe? What would we normally expect perhaps to see in the pathology and with diagnostic assessments, that this would actually sort of, what sort of trajectory would we expect? You know, so if someone has, you know, a disc bulge, would it be reasonable to expect them to lift 10 kilos in an acute setting of an injury? Perhaps not. But we may not need them to lift 10 kilos. We might only need them to lift 1 or 2. And we're looking at that capacity. So as allied health, we use a number of these different areas to be able to form our own opinions around estimating capacity. I'll hand over to Cass and she's going to take over the next couple.
Thank you. Can you just go to the next one? Thanks. Yeah, thanks. Okay, so wow, we're getting lots of information here. Is it all making sense and coming together? Great. So I'm just going to now move on to how we as allied health practitioners think about this pathway of recovery and how can we work better to support GPs in doing this. Now, Tan has already mentioned the really important thing that we do immediately, which is that we screen using the Arebro outcome tool, okay? This is a validated tool, and as Tan said, if somebody scores 50 or more out of 100 on the short form, they have an 85% likelihood of having a delayed recovery, and some of those people will never get back to work. So it's really crucial that we use that tool right at the beginning. And Fiona and I have been talking to allied health practitioners for a number of years about using this tool, and now many clinics implement this tool as soon as the person walks in and fills out their paperwork. Tan.
If you don't have access to the tool or don't have time to do the tool in the GP clinic, often a lot of the reports and the letters that come out from the GP, from the allied health team now have an Arebro assessment on there, as well as other assessments. So you could just use that if that, you know, if you're pressed for time or resources.
Absolutely. And we also encourage them to call you and say, hey, guess what? They're scoring 70 out of 100. I think we need to probably have a few more case conferences, etc., with this person. So that's one really important thing that we do. Oh God, I wonder if this will work. Oh, yes. They're the two guys who wrote the Arebro, just in case you're interested. Michael Nicholas is a pain psychologist researcher in Sydney. Steve Linton is in Sweden. and they collaborated. There is a long Arebro form, which is equally as valid and reliable. That one has 21 questions, and some people prefer that tool because there are certain questions in there that relate to their patient. So you can, again, use that tool, and if they're scoring 50% or more, they have that high risk of a delayed recovery, where we want to identify what are those issues that are going to get in the way of their recovery. And as Tan mentioned, you know, sometimes it's really obvious. People come in, they wear their heart on their sleeve, and we know exactly what the issues are, don't we? But there are those other times where everything seems to be going along okay, and by 3 months, it all goes out the window, and you think, oh my goodness, what's happened now? And there were these issues that were actually present back at the beginning, but the patient couldn't verbalize them, that, you know, they couldn't quite sort of put together what the issues were because they were so overwhelmed. And it's only much later that comes to the fore when it's becoming a real barrier. So, yep.
Some issues vocalized, but then later on there might be stress issues or mental health issues popping up. Is that still allowed under the claim?
That's a great question. That's okay. It's another slight segue. And there is, if you talk to the claims manager, there are a few services that are available. There's a low intensity mental health service, which is where they have CBT trained coaches essentially and counsellors available. The claims manager will make a referral to that service, and the person will receive a phone call and actually have an appointment within 7 days. And they have up to 8 sessions that they can utilise. Also with that, their immediate family can access that service confidentially if you ask the claims manager to refer the service for them. So it might be a partner who's not coping, you know, with this patient who's not coping, or maybe they've got a child doing their final year at school and they're not coping either because the parent's, you know, off the rails. So they can actually get some support too. So it's really important. We've certainly had really good feedback from the practitioners who have had patients using that service. With regard to psychologists, you just talk to the claims manager and they, I think they're usually Tan, correct me if I'm wrong. Yep, good. She's grabbing a microphone. Will approve X number of sessions if it's something that can be managed, Tan.
Can't stop me talking even though I'm sitting down. So with the first service that Cass was talking about, the early intervention mental health, the return to work support services, that's free. So the good thing about that, because often, as we know, to get an appointment for a psychologist, we can be waiting a very long time, by which point everything's just gone bad. So this service is free, even if the claim is undetermined. So when the patient puts the claim in, you don't know if they're going to be approved or rejected. Still, they still get the support. But all you need to do is ask the claims manager. So you don't need to organise it yourself. Just put it on that form in that magic box. Yeah, and they'll work it out for you. If you can't remember what it's called, just go early intervention mental support. Or I need help with psychological support services. The psychologist, however, if you are to refer formally to a psychologist, then that goes through the normal referral process. So that isn't a free service. That generally a claim would need to be approved before the psychological services get approved. Okay, so that takes a little bit longer, and then you will have to wait for a psychologist. So it's good to use these ones up front.
And thanks for bringing that up, because one of the important things that I'm about to talk about is actually, for this high risk group of people, is getting that support for them at the beginning. Just before I flip past this, so when you look at this form, if you go to our website and just put Arebro into the title, OREBRO, to think about that, it'll come up, and so you can access it. And it helps to highlight the questions that they're scoring high on are some of the domains where they're struggling a little bit. Okay, so just briefly, there was a big study done in New South Wales, and what they did was anybody who was scoring 50 or more out of 100 on the Arebro, they're the high risk groups. Okay, so in the control hospitals, they had standard care, GP, maybe some medication, maybe some physio or EP, etc. But at the intervention hospitals, in addition, they had early access to psychological support, right? So the blue group, yes, up there. The blue group is the intervention group. So we see a fairly usual recovery curve. And everybody got back to work. Sure, it's a bit delayed, but there may have been reasons for that. And actually, I think everyone bar 3 patients in this group was back at work by 3 months. So that was sort of the lead out for some of those more complex injuries. Now look at the control group. So at 6 months, it's all starting to go a bit seesawy, and at 2 years, it's even worse. And we can see that's going to continue. And we know these are the guys that don't do well. They're going to end up on disability support if they're not in our serious injury cohort. We really don't want them there. Now, look at that graph and imagine for these people here, if they were working at the intervention hospital and they had access to that early psychological support, right? Then they could be like everybody else here and they could have been back at work. They'd be having a totally different life. So I think that's the important thing. If you're seeing these guys and they're scoring 50 or more out of 100, try and get them involved with some sort of psychological support so that they can learn the strategies. Yep. Oh yes. So, sorry.
Cass, there's a question online regarding the Arivo short form.
Yeah.
Is there a correlation between the patient's personality or socioeconomic situation and the Arivo short form?
It's a great question, and I don't think that I've seen any research that is looking into that. I can find out. I can ask. I'll ask Michael Nicholas and see, but I don't believe that there's anything out there. But I'll take that on notice, and I'll get back to you guys, and you can share. Thank you for the question. I just wanted to say that using that early psych support, it gets people back to work more than twice as fast. Okay, so we're thinking about that risk of never getting back to work, increasing the longer they're away. Well, that early psych support, it gives them the strategies to be able to cope and manage with some of those situations better and have more confidence and be less worried about things. And at 90 days, we see again that intervention group, 5.5% of people are off work compared to 19.3% of the control group. So we can see as they step into that persistent pain state, we see the people without that psych support are not probably going to do that well. We do have brochures available. If you'd like some, let us know. We will post them out to you. This is the low intensity mental health support. You could give it to your patients, have a chat to them. They might like to go away and have a think about it, have a look online and come back and talk to you about it a bit more next time. I often say to people, look, I've had so many patients who have been children who've been incredibly assisted by psychologists. This is just like one phone call, maybe give it a go. And usually people are happy to try it. We do have another service called Reconnect. Now, this service is available to anybody, whether their claim is accepted or not, okay? And these guys deal with anything that is not related to the injury. Can you believe that? So all the other stuff that's getting in the way, maybe I've had a story where one lady had her autistic daughter, 18-year-old, left school. NDIS hadn't processed what was happening next. So she couldn't go back to work at that point because she needed to care for her daughter. So they got involved and they sort of facilitated the processing. So the daughter moved to her next stage of what she was doing, and then the mum could actually go back to work. So they're there to help with a range of things, and they're an amazing team, largely social worker based team, and they're based at the Return to Work SA offices. I could give you lots of examples, but we're running out of time. Just briefly a note to say, having an injury at any time is stressful, okay? And it's important that we let the person know that this is actually quite normal to feel this way. Having a work injury, even more stressful. We've got all these extra people in our lives now asking us, how are we going? What's going on? What's going to happen next? And if we have all of those people telling us different things, you can imagine how terrible and confusing and stressful that is for the patient. And that brings us back to Tan was talking earlier about it pays to care, and having that cohesive care and cohesive conversation with the patient and setting those goals as a team. So Tan's already mentioned case conferences, and particularly in these high risk patients, I think we need to really use this well and use it regularly. Get the team together early, do it early. You know, maybe maybe Fiona or myself would have been out to do a workplace visit, and we can gather information and bring that to the case conference about what they can do, what they can't do, what they're already doing well, and we'll have some video footage of it to share with you because you won't have time to go out to the workplace. So that can be incredibly helpful to deal with some of these trickier claims, okay? And setting that next case conference and things to achieve by then, it really keeps everything on track.
Often we're time poor in the clinic, and we want a case conference, but you know, I wouldn't have time to send out 10 emails to try and get the team together, and wouldn't, you know, I may not know who to bring together. All you need to, if you're not sure, the claims manager is a really good point of call. All you need to do is say, I want a case conference, again on the magic form, and it'll happen. They'll call the clinic, they'll organize the physio, everybody, the employer even, and they'll get everybody in the same room for you, and they'll book out a long consult so that you can spend some time with them. So you don't have to do the legwork. Just while I've got the microphone, the services that Cass was talking about, Return to Work SA have a lot of them, and generally they're all free. Some of them are available, as I said before, even if the claim's undetermined. Some of them require determination of the claim before it does so. If you're not sure, again, on the form, and the claims manager will contact you and talk to you about what's available now and what may not be available. Having said that, the Return to Work SA services are only available to, remember the 2/3 and 1/3 of employers that I spoke about before. So the 1/3 that are self-insured, where their insurance is self-funded, they aren't eligible for this Return to Work SA services. But the 2/3, the smaller companies and the medium-sized companies, the 62,000 are eligible. Okay, so again, if you're not sure, just ask, because sometimes the self-insured have their own programs, the EAP programs, but you know, that may not be obvious, or the employer may not have offered it to the patient. So if you've done an Arebro or read on the physio form that the Arebro is, you know, above 50 and you feel that they need a little bit of extra help, speak to the Return to Work coordinator from those larger companies. Yep.
Right. Before you go on, there's a question that's been raised. Is there any advice for patients with chronic pain or on drugs of addiction, such as benzos or opioids, prior to their injury?
Yes, lots of advice. So I'm going to Return to Work SA have a seminar coming up on pain management, and it's going to be run by Dr. Tuan Vo, who is a pain physician. So I don't think that question can be answered quickly in this forum. Happy to talk offline to the person and maybe give them some preliminary advice, but perhaps I may refer them to the seminar that's going to be conducted in. Absolutely. Yeah. Okay. Is that is the participant happy with that? Yep. Thumbs up. Good.
Okay, we're going to keep moving on. I hope we've still got volume, okay? Because we do want to get to the really meaty bit, which is you involved, not us talking all the time. But a couple of key things here with this one. I think the other thing to remember is your allied health team. We're not just doing our clinical work. You know, Cass and I spend a lot of time at an undergraduate level with the students. We go out and we talk to providers all the time about upskilling them and making sure that they understand how to work within the psychosocial domains of the Return to Work scheme. So it's, as well as providing the physical treatment that the OTs, physios, EPs do, we're very, very good at mapping that pathway to recovery. So this is done very early on in the piece. The conversations that we have with injured workers, as Tan mentioned, are about setting expectations. What's the likelihood? What's my role here? What are we expecting from you as the injured worker? And we have those discussions really early on, so we can set some timeframes, we can set some realistic goals, we can build confidence, not just capacity, but we can build confidence in understanding their injury and potentially where that sort of that pathway and that map is going to look like. So I said, utilize our, the allied health team that you have, because we can do more than just provide the clinical treatment there as well. We use a management plan. I won't go into a lot of detail on this. This is on the website as well, because we do want to get to sort of really looking at estimating capacity. But this is a tool that all our allied health providers will utilize. It goes through goal setting. It looks at some of the psychosocial and outcome measures that we've just mentioned. We talk about the issues. There's a little section just down the bottom which does talk about issues. So if the physio, if the EP, if the OT, whoever is identifying that there are some barriers, and like I said, people talk to us a lot because we spend a lot of time with the workers. So if we're picking up that there are some barriers to do with fear avoidance behaviours, or it could be problems at work, or it could be all sorts of things that are non-necessary injury related, we can identify those and pop them into this management plan. This is a plan that also is done in conjunction with the worker. So it's a tool to be able to sit down and have those discussions with the worker about what we believe and what we're going to be working on together to map that pathway. And it is sent to all the treating team as well. Okay. The FAB tool is pretty much what our abbreviated version of the functional ability recommendations tool. So as you can see, by the powers of all sorts of magic here, it actually replicates that section E of the work capacity certificate. So as allied health professionals, the second page of our management plan is actually this functional ability recommendations tool. So as allied health providers, we're upskilling our providers, our industry, in how they can assess capacity, how they make an opinion in their scope of practice around what capacity looks like for that worker. So then you almost have, I won't say the work done for you, that's not right, but it's another opinion from an allied health professional to help you in formulating that work capacity certificate. So this is a standard tool, as I said, that all allied health professionals working with injured workers would be very used to filling out. So it can be on their letterhead. You could ask for one if you're not getting one. Certainly engage the provider, talk to them, ask for this. They will know what you're talking about, but it should be something that they're doing more and more frequently now.
Ask, how many of you have received one of these FAB tools? Oh my God, Fiona, I've got to find out where they are and talk to their providers. Okay, God, normally we see lots of hands. Never mind. Anyone online? Let us know. Can't see anything in the chat yet. And hopefully they'll be all clicking away. So look, this is great because I have to admit to you, in this small cohort we have, many years ago, I did get a phone call from a GP who said, Cassandra, look, I love your letters, love your work, everything's beautiful, but can you just make it a bit shorter? So, so when, I thought about it and I thought, well, if we're writing a letter, you guys, you've got to spend your brain time translating. What does that actually mean here, right? Why don't we just write it on this form? It's just so much better for everybody. And we've got that time to talk to the patient about this as well, and make sure they're in agreement with what's going on this form, and then share it with you guys. So, hopefully then that's much easier when it gets to your end. Thank you. So look, the next thing I'm going to talk about are workplace visits. We've mentioned this already. So exercise physiologists, physios, OTs, we can all go out to the workplace. Now, what's really important is that we do this as treating providers. Okay, we know the person, we know what they're worried about, we know what they can do, we know what they can't do. So if we go out to that workplace, we have a look at what a day in their life looks like, then we learn more about the job so we can tailor our treatment to prepare them to go back to work. But we can also have a look at those tasks and they'll say, look, Cass, there's that thing over there I was telling you about. I'm really worried about it. So, right, well, let's just come over here. Let's have a look at that. Tell me about this. What are you worried about? Okay, I see what you're saying. Now, excuse me, employer, what about if we actually change this a little bit? We could take this off the ground and have that at this height. Is that possible? So then we're going to address their concerns and work on it as a team. And it's really important that the employer plays that active role and they feel a lot more empowered and they're more engaged as somebody who's going to be proactive throughout this process. So it works on so many levels. And as I mentioned, we can bring that information back to the case conference. And share with you what's going on. So we need to see more of these sessions going on. We have up to an hour at the workplace. We get paid for travel there and back. There's no official report. We can write a report if people want it, but this is about using this opportunity as a way to help somebody learn and become confident in their tasks. Can I ask all of you, if you think about your patients when they're going to go up to the next stage of their return to work plan, is it generally 9 a.m. on Monday morning? It is for me, most of the patients. So then they get really worked up all weekend thinking, oh my goodness, on Monday I've got to increase, I've got to start doing this task or increase to this many hours, and they start getting worried about it. So instead of that, Fiona or I, we could be going in there 2-3 weeks, the week before, and practicing these tasks with them so that they're really confident and they're actually excited to be going back and progressing onto that next stage. So you can really change that, reduce the cortisol and make sure that they're actually going to have a good day and not a bad one. The last thing that I'm just going to mention is discharge planning. It's really important for us. Fiona was saying with our goal setting, we think about clinical patterns, what's the likelihood, what's the sort of time frame we're looking at here at discharge. We must have those conversations at day 1 and day 2. And every time we review, we come back and we look at that again. So we keep setting those expectations that Tan was talking about and making sure that we stay on track. Does that all sound okay? Great. No questions from the floor over there? Great. Case study.
So I think, yeah, sure. So we've got 3 cases. These are real patients. And we're, as mentioned before, we're going to split into 3 groups. All the information is on the packages that we've given. So I think we won't read through the cases, but we'll work through 1 case each.
And for the online people, I'm just going to talk through Mr. Neville, which is actually Tan's group here. So Mr. Neville is a 55-year-old man, 14 months post left right rotator cuff tear. Work history, self-employed air conditioning technician. He had a fall in a public place, most embarrassing. Rotator cuff tear, which was repaired. There's legal representation, which is heavily involved. His past medical history is he's had 3 previous work injury claims, no other significant past medical history. On physical examination, he has full range of movement and 3 out of 5 general strength. So have a think about that, you guys online. What are you going to certify him as? And let's go over to the team over here.
Just quickly, in the interest of time, we've decided we're going to do 5 minutes. So we don't have to address every question. Maybe if we can just maybe bring to the table some pertinent points, and then a little bit about how you, because it is a talk about determining capacity, we probably should talk about that a little bit. Okay, but maybe just 5. Don't worry about 10. Yeah, you can do it on the spot. This is what it's all about, too. You can do it on the
spot. As a team, we didn't get to talk about the functional capacity filling form yet. We just discussed about his presenting complaint and what might be the prognosis. We reckon that this is something is very tricky because he is self-employed. That means he's the employer as well as worker, and he do have lawyer heavily involved and with the previous work injury claim. But good thing is that he's got full range of movement and 30 out of 5 general strength, which is pretty good results. So what we think that he should be able to sit and stand and walking without any restriction, and kneeling and squatting shouldn't affect. But carrying and holding and lifting, we need to discuss with the patients and see whether how much he agree with our decisions. And reaching above the shoulder, he do have a full range of movement, but we don't know exactly how much his lifting capacity is and how much he's feel comfortable with. And bending shouldn't have any issues, and use of affected body parts to be modification, and neck movement shouldn't be any problem. Climbing steps and stairs shouldn't be no problem, but ladder, he might need to have some modification, and driving, he should be able to do so without any restriction.
Thank you.
So this one is a complex case. I'm not going to talk about all the complexities. We have talked about it at the table, but I just wanted to point out that sometimes, even though they have capacity, so we will say that, yes, you can lift X amount of kilos, sit for the X amount of times. For him, he actually can't do his work. So it's not entirely untrue that he has no capacity. It's not entirely untrue that he can't go back to work. He has capacity, but he can't go back to his previous work because he can't lift he runs his own business. How can he install an air conditioner by himself with help of 1 or 2 person? And he can't employ more people because the company can't afford it. So really, it's true. He can't go back to work, but he has capacity. So how do we get him back to work? Tricky, right? So there are ways, and this is why I want to talk about that. There are ways. So this is when you call the team in, because you don't have to solve all the problems yourself. He is the employer, so he is the team of the employer, but you might want to get the physio, the OT, the claims manager. The claims manager is very helpful in this case because they may be able to find a host employer. So then he gets all the benefits of being back at work or rehabbing at work, but not with his company. So he may be able to work for a different air conditioning company or other company. It doesn't have to be an air conditioning company. It can be selling clothes if he's interested in clothes, or something else that he may be interested in, that he can just move about and use his shoulder. So in this case, he became an air conditioning consultant for a different company. So he did quotes. He went out and he was the helper for other people. Yeah, so he started slowly because he hadn't been back at work for 14 months, but then he went out for I can't remember the company, but I probably shouldn't say. So so he went and with the help of the claims manager. So not from me, because I don't know what air conditioning companies need an employee. So that's when you get the team together and they will go out and do your legwork for you. Yeah. So he can't go back to his work, but he can go back to work. Yeah.
So Tan is just saying that because he was certified with the capacity that he had, the claims manager was able to find an alternative host employer to give him employment that he was able to do. It was within his capacity. So it's really important that we do write down what that person can do right now. Beautiful. Thank you. That was a great example. We're going to go to we're going to Donna next. Okay. Oh, gosh, I got me confused here with the pages. Wow. Okay, good.
That's right. Our group had Donna. Have we got the group or?
You've got the group online. You can invite them to unmute.
Oh, look, my wonderful group. Can you unmute? Is there anyone there that wants to talk a little bit about this? I'll just give the background for everybody else. 47-year-old female. There's an undetermined psychological injury claim with this one. She's a disability care worker. Had an alleged assault at work with a razor blade by a resident. There's no physical injury, verbal and near physical. There's a little bit of history of domestic abuse, but no other significant past medical history. So we talked a little bit about, where would you actually start with certified capacity in this particular situation? So have we got anyone in room 2 that wants to jump off mute? I said there's no right or wrong here. Catherine or Brooke, I'm going to dub you in.
They're not putting their cameras back.
They're not
on.
putting the cameras back on.
Put your cameras back on. as
You
well.
guys had some really good.
Oh, look, you've got Catherine. Catherine's
Oh,
joining us.
thank
there.
you,
Oh,
Catherine.
thank you, Catherine.
I dubbed you in, but thank you.
Yeah, so we talked about this worker that early on that we could maybe involve the employer and the claims manager to. We also need a bit more history about exactly where she worked, like what the physical environment was like, and what her issues were, whether it was a particular incident or environment. What was the environment that had caused the problem? Was it something to do with maybe past domestic abuse that might have triggered something? But trying to find out if there was with the claims manager where if there was something that she could do with an exercise physiologist also while her claim was being determined, to keep her active rather than just being at home doing nothing, which could spiral her down into more mental health issues. Whether she could access the early intervention psychological support as well, but getting out there, maybe someone could go out and do a workplace visit and have a look at the environment and see what was going to be possible for her to do, or which areas of the place that she could go back to, or what she was comfortable doing.
Yeah, look, Brooke, do you want to add anything to that, or?
No,
Just-
I think Catherine covered pretty much everything we discussed very well. Thanks, Catherine.
Yeah, look, a great summary, Catherine. It was basically something that we obviously looked at, making sure that we engage the employer and the worker. Is it a particular, if it's in a residential care facility, is there a different part of the building or the facility or the employer that would remove this particular worker from that resident that may minimize this sort of happening again? So is it the environment that was perhaps the cause of the psychological concern? Is it something that was at the incident themselves? But we all agreed as a group that one of the key things here was like, how could you facilitate some return to work? Absolutely engaging a whole team, certainly psychological support, but even though there's no physical injury, engaging active therapy very early on to ensure that, mood is enhanced and we're not sort of allowing, dare I say, that sort of spiraling into more mental health. We know that work, as Tan mentioned before, work is good for our health. And yeah, making sure that there is hopefully some connection to the workplace that is positive and maintains that, but acknowledges the safety aspect of the worker. So Tan, I know you know this worker. Have we done this case study some justice? Thank you. Great. Good work, team two, group two.
Fantastic. Thank you. Now I'm going to ask Suraj, who very kindly volunteered with a tiny bit of subtle suggestion from one standing right here. So we looked at Mrs. Angelica, 55-year-old female, 4 months post left meniscal tear of her knee. Work history: she's a cleaner in an aged care facility and she had a fall at work on a slippery floor. No other injuries were reported, thankfully, and there's no other significant past medical history. On physical examination, so she's now 4 months post injury, she has 3/4 range of movement, 3 out of 5 strength, general strength, and some mild swelling. So that bit's good. So Suraj, we talked about some questions, but maybe should we go into the table? What would we put down as our recommendations for this lady with her functional abilities?
So I think, we discussed in the room that obviously there's a lot of different scenarios that this case could come with. So the fact that she's been off work for 4 months, so firstly establishing whether that meniscal tear is, how significant it is. And we sort of took the scenario where it's a mild meniscal tear, which potentially doesn't need a surgical intervention. In terms of the physical examination, I think the main thing that stood out was the 3-on-5 power. She was not presenting with any locking. which is a good sign. So there's a definite role for getting back to work. Because she's been off for 4 months, we figured she can start off with like a 3-hour, 3 to 4 days a week start. Obviously establishing that based on what she's been doing at home for the past 4 months. In terms of initial restrictions, we established lifting potentially more than 10 kilos if she's been, if she needs to carry a vacuum at work. There might be some issues in terms of tripping hazards and things like that. So at the start, that would be definitely a restriction. Weight capacity, depending on if she's shopping and she's carrying a 12-kilo bag, then we could start off with a restriction about 10 kilos there. That probably covers most of the things. Bending, I mean, she's already got 3/4 range, so I wasn't too concerned about that as such. It's probably a good rehab for her in some ways, and we could test that in a work environment and see if she copes with that. And I wouldn't put that as an absolute restriction.
Great, thank you. And yeah, so I think we mentioned standing and walking. Again,
Yeah.
she should be okay with that, but perhaps with the ability to have some intermittent sitting. And we also thought no kneeling and squatting at this point. We didn't want
Yeah.
to aggravate her.
Yeah.
And just a note on bending, often it's easy for the patient to think about where things are in relation to their own body. So if you're thinking about bending, initially we thought if this was earlier on in her injury, maybe she could bend to her knee so that then she might just be having a little bit of knee flexion. And as she's improving, perhaps she can bend to get light, items of say 5 kilos from about mid-shin height. And then that's something she can actually remember to work with her. No problem with neck movement. Climbing stairs and ladders. Luckily, she works at the Royal Adelaide Hospital and they've got a whole lot of lifts there. So that's okay, isn't it? We're a bit lucky. But trolleys. Now, trolleys, I guess if someone has to push trolleys around, you could put that in, where would you put that, Tan? Oh, you put it in the box. Okay, Tan puts it in the box. That's great. Thank you. And so what we've done on the Fab tool is I've got 2 blank lines. So we encourage any specific activities, we encourage the allied health practitioners to write them down. Just didn't think of that, the box. So you GPs can just put it in the box. So, maybe there's a particular trolley that is going to be problematic because it's heavy and big, but the other certain trolleys are okay. Write that in. Because they'll be telling you what they're worried about. Nobody knows their job like they do. There was one more thing that I was going to say. What was that? Oh, I know, slippery floors. So we just also mentioned sweeping. We're going to work on the technique, except I haven't got 2 hands. Like that. Okay, not that. No. Okay, so technique, get the allied health in there to work with them on their technique, doing things. But with mopping, there is that slipperiness too. So maybe with the mopping, she just stays off that until she's a bit stronger and able to protect herself a little more. I reckon that was probably it, Siraj. Does that sound about right to you?
That sounds about right. Yeah.
All right. Thank you so much and lovely to see you. And thank you all of the team for your input.
Thank you.
Everyone had lots of really good comments that we don't have time to talk about. Thank you.
So now we have 10 minutes of Q&A. If you have some question, yeah, if you want, yeah. People online, please feel free to write in the chat your questions. Do you have any questions to do? Yes, I have online people, please feel free to write in the chat your questions.
Can I add something? I just want to add something that I learnt from somebody who certified a patient who was a bit hesitant about going back to work. Another physician colleague of yours, Tan. And I thought, gee, that was a good idea. So they certified this person to start back with quite restricted hours for 4 days. Then after that, they increased it. They said from this date, it's going to be this amount. and then they saw them 2 weeks after that. So they said that was particularly useful for those patients that come back and say that they're worse or they don't want to increase, because it meant that there wasn't the opportunity to have that conversation. They just increased to that next stage and they were really confident that they were going to be able to do it. So, you know, that can be a helpful strategy. I just thought I'd mention. I thought, gee, that's good. I'll keep that in mind.
All right, there has come through a question from online. So thoughts on work conditioning or functional restoration programs for the chronic long-standing return to work clients? Who'd like to take this one first?
I was actually just going to say anything that gets people moving and active and engaged and building confidence and having conversations is worthwhile in my eyes, whether that be in a more formalized functional capacity or work conditioning program, because there are some programs out there that they spend a lot more time going through functional retraining, putting them into sites where they simulate lots of work duties. So whether it's that sort of more formal approach or through physios, EPs, whatever, anything that helps to build that confidence. And I think that the point that I was going to say too is it's around the language that we are all talking, because often what happens when the worker is injured, sometimes there's that sort of the negative connotation that, you know, as we often get say, you've now got a back of an 80-year-old, you can't do this anymore, especially those long-standing, sometimes the language that's, you know, that they're hearing, we want to make sure that we can turn that around. So in my eyes, anything that gets them moving and confident is worthwhile.
So functional retraining, absolutely, that's what we're doing, functional retraining, but it comes in a number of ways. So what we're looking at here, the functional retraining can be done at work, it can be done at home, it can be done in the gym. So the general hierarchy system that I have in my mind when I'm seeing a patient is as such. The absolute top ultimate goal is to functionally rehab in their own job, doing their usual job in the usual hours for the usual amount of time with the usual amount of pay. That's the absolute ultimate. If you can't get the same job in the same place, then the next hierarchy down is functional retraining in the same employer. So it's really important, this contact and this continuity with the employer. So you want to stay with the employer, but choose a different job within that employer. If that can't be achieved with all the help that you have around you, the next hierarchy down, if you can't go with the employer, is to go with a host employer. So you can get the claims manager to help you with that, because there are people who can look for host employers for you to do a similar type job to what they normally do. The next one down from that, if they still can't achieve it, is a host employer with a different role, volunteering, Salvation Army, you know, a completely different, lighter, more sedentary role, but with a host, with a different employer. So same job, same employer, different job, different employer. And then absolute last on my list, sorry guys, is the simulation training. And the reason being is that, yes, it's good. It does provide a lot of benefits. You know, there's movement, there's getting out of the house, there's retraining in a controlled environment, which is a good part, but it can sometimes be a little bit sterile, and sometimes patients get amotivated after some time. But these simulated training, I gather this is what this participant is talking about, are good for the patients who are absolutely terrified of going back to work. Because if you can prove to them that they can do that same movement, right, in a controlled environment, then there's no reason why they can't do that same movement in their usual environment. So it's a good place to test what they can do. But I certainly wouldn't recommend doing that long term. It's you know, if they can't do all these other things, then start somewhere, and it's a good place to start.
That's just led me to think that, particularly as you said, if there is no vocational direction, I think that's where some of those programs can be beneficial, particularly if yeah, as Tan has pointed out, or the sort of the hierarchy of order, if there really isn't any sort of vocational direction and they are looking at something else, for a work conditioning program to really work, we've still got to understand what are the goals, what is the vocational direction that we're trying to take.
To go back to work, either start with lower, lesser hours, where the employer is on board and sympathetic and cooperative and encourages, there's absolute success to getting back to where they were working full time, So I think that's a very important thing to get them on board to understand. And that really is very successful.
Absolutely. And 100% agree. And we would, as allied health professionals, make sure that that is the ultimate goal, that return to the same employer, same duties, same hours, same everything, pre-injury, absolutely. And you're right, when we do have the employer and everyone on side with that, it generally makes the process a lot smoother.
Perfect. I was just going to mention, and a way that we will achieve that quite often is we might go out to a workplace to do a workplace visit, and the employer might say to us, "Oh, look, I think they're just trying to pull the wool over my eyes. They just lifted up that 5 kilo thing from the ground, and now there's this whole claim, and they're quite angry about it, right? Not a good relationship between the employer and the employee." And so we'll come along and say, "Oh, okay, well, I understand why you think that. But in fact, if we think about what that person's been doing for the last 3 years, they've been lifting 20 kilogram bags of coffee from this location and moving it to that location at these different heights. They've been doing that for 8 hours a day, 5 days a week for 3 years. This is really common that we see that, this is like the final straw that's broken the camel's back. So this has been the thing to just push them over the edge. And you'll read about it all throughout the literature. So it's quite, quite a common thing, nothing to worry about. Everything that we see on assessment is in keeping with what we would expect. And I can also reassure you they're highly motivated to get back to work. And they're, oh, really? Right. Okay. So everything starts to make sense to the employer, and then they're much more engaged because they get it. They understand, and it does really change that relationship between the employer and the employee. And you'll find that they're much more collaborative, and they'll say, what about this task? Would that be a good one for now? Yes, fantastic. What about this one? Actually, that one, maybe not because of this. Oh, right. So maybe this other one. Beautiful. So they really start to understand what we're trying to achieve.
Okay, there's another question in the chat, and we might take this as a final question in case, unless anyone has any final burning questions. So this is a scheme-related question. I'm an occupational doctor and not the person's regular GP. He's come to the end of the claim, requires long-term analgesics, pregabalin. Who will be responsible once the claim ends?
Yes, that is. Who will be responsible? Ultimately, not return to work, SA. After it is a little bit more complex than that. The claim, as mentioned before, so after 12 months, they go down to 80% of income support. And then after 104 weeks, they go down to 0 income support, but that's only income support that stops. They still get medical for another 12 months. Okay, so they'll get 3 years in total maximum of medical support, unless they are permanently impaired, basically. So what they need to do for that is a whole person impairment. So they'll need to go off and have an independent medical examination for a whole person impairment. And then if they get above a certain percentage, then they will be considered as seriously injured, or and then that's when they get long-term support. But they only get long-term support if they are in that seriously injured basket. So if they're not, then all the care goes back to the public system and or the private system, or themselves, or self-funded. Does that answer the question? The only caveat to that is that if they do go back to work full pay, full capacity, full hours, then the 12 months of ongoing medical support will start at that point. So they may not get the full 3 years. Now, with those scheme questions, there's a lot of legislation, but we don't really need to know all of that as GPs. It's important to know the 12 months, 2 years, 3 years point. But if there's any questions, the best person to ask is the claims manager. Just put it down on the form. I need to talk to you. Come and talk to me, and then and get the patient there as well. And you can get all of those questions out at the same time, because it really, there are little nitty gritties. Does that answer the question? Yeah. Yeah. And if that still doesn't answer all your questions, then you can call Return to Work SA. So they have a hotline basically for anybody, but us doctors can call them and they'll triage. So if it's a scheme question, they'll put you through to someone who knows about the scheme and explain all of that. If it's a clinical question, they'll put you through to one of the medical advisors. So it's just one number that you call, 83587575 5757. 5757 again. But Helen will send that out to you.
Can they add on top of that with the mental health care plan from a GP if they need to see psychologists like urgently? Wow. Yeah. So they're still able to do that. Yeah. 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 Out of the pocket, boy. But then the claim can, if that's approved, then they can claim back.
Exactly.
Is that right?
Yes. Yeah. Yes. So they can, that's right. They get, so if the claim's undetermined, then they should just keep all of that. They've got a choice of receiving interim payments. Yeah. If they choose to. Otherwise, so if the claim gets accepted, they don't have to pay anything back. But if the claim doesn't get accepted, then they sometimes do. That is a whole new kettle of, that can cause problems as well. Yeah. Psychologically, on top of the psychological claim. Yeah. And that was actually one of the problems of Miss Donna. Yeah, accepted interim payments. Yes.
If I don't do all of the circles and just write press C here on the right-hand side, that should be acceptable?
That's fine. Some doctors fill out nothing. Yeah. So really that's also a tool to actually help the patient. So sorry, can I? Yeah. There is something very important that I also want to say from our GP point of view is that we don't have to find the work for them. That's not our job. We don't have time. We don't have the capacity. We don't have the capacity or the knowledge sometimes to find the work for them. All we have to do is certify what they can and they can't do. That's all. Then it's the rest of the team that will then go out and forage for us. And that's how we get the effect is to get everybody to help. Yeah. But don't even try to say, you can lift that box, but not that box. Yeah. Just say 5 kilos. Full stop.
Well, thank you everyone for attending to this workshop. We invite you to join to our next workshops that are also funded by Return to Work. We have the musculoskeletal injuries that we will focus on the knees and shoulders, and it's just a face-to-face event and will be on the 11th of May, Saturday. And also we have the medical legal responsibilities that is on the 27th of June. And that's a hybrid event as this one. So you are more than welcome to register. And well, I would like to especially thanks Cassandra and Fiona for joining today and for sharing your knowledge with me. So thank you very much.